sleep disordered breathing makes me bananas. Sleep does not disorder our breathing. Breathing disorders our sleep.
Hi guys, Melissa Mugno here. I'm the host of the podcast and I want to thank each and every one of you for tuning in. You know, I wanted to do a bit of an intro to the podcast because I've been getting so much great feedback, but people asking, what if I know nothing about what you're talking about? What am I listening to? How can I share this episode? And I wanted to give you guys a little backstory. I created and developed Mind Your Mouth podcast because I wanted to have conversations with people in the space or the movement in which we call airway, self-help, nervous system regulation. Because let's be honest, we're all human, having a human experience, trying really hard to either sleep great, be able to manage our human behaviors, or develop and raise our children to be great people. And for a lot of people that don't realize, there is a lot of biohacking or low-hanging fruit that's out there, and that is called paying attention to what's going on in your mouth. And that's what each of these episodes are about. I'm talking to people that are either industry movers, leaders, doctors, medicine, functional health, or just people that are trying to make an impact and realizing that inside is where it all starts. And so I hope that these episodes make you look at things from a different perspective or open your eyes to an industry you didn't even know existed. If you feel called or you're interested, I can't ask you enough if you could do me a favor. If you could please subscribe, like, or share and send this to somebody who may be struggling or maybe feels alone, wants to develop a business, or is struggling to just feel comfortable in their own skin, it would mean the world so that we can continue to grow and also have a little fun while we're at it. Thank you guys so much. And please stay tuned and watch out for this next episode. Well, hello, and welcome to another episode of Mind Your Mouth. I am your host, Melissa Mugno. And as always, I am so excited for today's guest. I am really excited about this conversation. As most of you guys know, I normally tend to have people on the podcast that I'm really, really close with. But as the podcast has been growing, I've been so blessed and so honored that I'm starting to create so many new relationships and contacts. And this next guest is one of those. The power of social media, the power of consistency, and having a really authentic message is what lands you the opportunity of building new relationships. And today we are going to meet somebody, have a great conversation, and get into all the things that make her nosy. Let's introduce and welcome Dr. Karen. It is such an honor to have you here today.
Thank you so much. I love the name of the podcast, Mind Your Mouth. It reminds me of like Mind Your Manners.
Yeah. Yeah, it definitely is mind something because you know, a little story just to go back with it is I was always told as a kid that I was a chatty Cathy and never shut up. And every report card said talk too much. And it's interesting. I literally just made an Instagram or a TikTok that said me walking on stage saying, I wish I could call every one of my high school teachers and tell them that I did actually make a career of talking too much and I do get paid to talk.
You know what? It's so funny you mentioned that because I had a high school teacher back home. So I was, I'm Southern by blood.
Okay.
North Carolina, Georgia area, but was born and raised in Ohio for a greater part time. Went to UNC Chapel Hill. And I had this English teacher. She was my composition teacher, Mrs. Cackler. Oh my gosh. I could never do anything right in her eyes. Never.
Yeah.
And like 3 books later, I wish she could see me. Exactly. How do you like me now?
There's something beautiful about the process of having to, right? I'm a big advocate of the journey, right? Like the journey matters. And, there's every person comes in our life for a reason, a season, right?
Or a lifetime.
Yeah, or a lifetime. Exactly. But it's interesting that a lifetime, there's only very few people that, it's a very selective few that stay in for that lifetime, right?
Yeah.
But the reason and the season are really instrumental in getting you where you're at, because I don't know about you, that I needed that little bit of fire. I needed somebody to kind of say,
Yeah.
oh, you can't do that. You can't do that. Because then
Yeah.
I was always the one that'd be like, why? Why can't I do that?
Oh, I still have that. You know what I say?
Hear me out.
Watch me now.
Well, Karen, Dr. Karen, what can I call you Karen or do you?
Please, just call me
yeah.
Karen.
Well, Karen,
I always say Karen, but I'm not a Karen.
You're not a Karen.
And
That
you know
is
what?
so true. Okay, I love that you just said that. You acknowledged it right away.
Karen, not a Karen from the 1960s. It was a very popular name. And I should get royalties. We should all get royalties for that meme.
You should. Anyone using it, which, I actually love that you just brought up the Karen situation because one of the things with myofunctional therapy and breathing, and we're going to go here, but then I'm going to have you transition and just introduce yourself a little bit to the audience. So I have a consulting firm that we teach a lot of dentists and ENTs, and I know this is your world, how to have better systems and processes. And whenever they say to me that they don't have patients, and I said, how many Karens do you have in the practice? Or how many patients are like your Karens? And I only say that, I go, you show me somebody who's overreacting, having a resting face.
Which face?
Yeah. And they are hyper anxiety, hyper super focused, trying to control things. I said, and I'll show you somebody who has a breathing issue or a sleep dysfunction.
You know what? That is so true. And I have to tell you, so my website is up and running now. Little plug.
Congrats.
Yeah. So it's
of course, plug away.
Yeah, it's drkpd.com. And if you scroll to the bottom, it's on my about page, but if you scroll to the bottom of the homepage, you see my resting witch face. And my friends have been laughing at it. They're like, girl, that picture you have, like, dare me. Just dare me.
Which, to be told, I went on a great deep dive between your book and watching some podcasts. I saw you were on my good friend Mike DeLuke's podcast. I watched.
Oh, yes.
Yes, I watched that. And I went on some really great things and some interviews. And what I loved about you, one, is your story. Your story is fabulous. I know that was something you and Dr. DeLuke talked about. The story is what makes it really special. The journey, I'm all about that journey. And so you do have a really amazing journey. You've, starting from trauma nurse to then being in the Air Force. I mean, can't get away from air, right? You're either up in the air, around people in the air.
What? Melissa's been full circle. And it kind of leads me to this, brief introduction.
Yeah.
You can read everything on my website, so I won't bore you with the bio and credentials.
Thank you.
But what's really interesting is in 1983, I started out in a respiratory therapy program.
Okay.
So I had, like I said on my website, I had a little flirtation with lung physiology.
Okay.
I couldn't do suction. Y'all, I could not do suction and sputum. Couldn't do it.
So you couldn't suction?
I was like, oh, couldn't do it. So I went and I was a veterinarian technician. And I was like, good, I'm going to go to Ohio State. I'm going to be a veterinarian. I loved the large animal farm calls. But the small animal ones were really getting to me. And I'm like, I can't put an animal down. And I wasn't in a very good area in Northeast Ohio. So there was a lot of inadequate care for small animals. People just drop off their animals. I'm like, I can't do this. So that's when I found nursing. So fast forward, I left Ohio, went to Chapel Hill, UNC. Absolutely love Chapel Hill. So I'm a Tar Heel. Love basketball.
I actually went to UNC Wilmington. Couldn't get into Chapel Hill, but I was down in Wilmington.
So we are connected then. We're in that UNC system.
My grandparents left New Jersey, moved to Clayton, North Carolina when in the late 80s. And my grandfather pretty much, massive immigrant. And he said to me when I was in New Jersey, he was afraid that I probably wasn't going to get into school in New Jersey. So he changed my residency and I went down there. And that's when Dawson's Creek was being filmed.
Oh my gosh. Yeah. Oh my gosh.
As soon as I saw that, the UNC connection, I thought, oh, that's so cool. So that's awesome.
Well, it was kind of a odd way to get in because I didn't have a 4.0 as an out-of-state student to get in, but I made it there and I graduated, from UNC Chapel Hill from my undergrad in nursing. And I thought I was always kind of intrigued by like operating room stuff. And so in the nurse extern program, I got my first choice, which was recovery room, because I thought I wanted to be a nurse anesthetist. And if you know me, I cannot sit still and pass gas. So I'm like, nah. So I stayed in the recovery room. Then I moved after graduation. It was actually the nursing job fair. And
so wait. So you wanted to know, so you were always intrigued by the airway.
I was.
Yeah.
Between respiratory therapy school and then the veterinarian side of things. And I talk about that briefly, why animals are actually nose breathers and not mouth breathers outside of respiratory distress because of the location of the glottis to their soft palate. So I went to this nursing job fair at Chapel Hill, and I was like, oh, recovery room, because I was doing my nurse extern program. I just wanted to work in the recovery room. And I was like, by the water, I wanted to live by the beach, do recovery room. That would be a dream. And MUSC in Charleston was there. Medical University of South Carolina was there. And it was a recruiter. She said, okay, let me talk to the nurse manager and have you come down for an interview. So I'm all excited. I go to Charleston for this interview, and it was in like February. And I go down there, and her name was Karen Cronin. I'm forever indebted to her. And I'm in her office, and she's like, great interview. I love your passion and your background. You've been in the recovery room for a year, although as an extern and not an RN. She said, well, you don't have your CCRN, which is your certified critical care RN.
Okay.
Like board certification. And in order to get that, you have to have 2 years of experience to take that exam and the course. And this was back in 1992. So I said, Karen, let me make you a deal. Bring me on as your first new graduate ever. Let me take my CCRN. And if I get a 90% or less, then kick me off to the floors. Okay, deal. She's like, okay. And so I was the first ever new graduate down there. What was really interesting, and here's where I really found my niche. Like, this is my purpose.
Okay.
There was an anesthesiologist, Dr. J, always had a coffee smell and a styrofoam cup of coffee every time he'd walk in, kind of follow up and check on the patients. I had a patient that wasn't doing really, really well, and they had an arterial line. And so I called him like, hey, Dr. J, I want to do a quick ABG. I just don't feel comfortable with this patient. So I draw from the arterial line. We had a little room where we could just inject the blood into the ABG machine and boom, get a readout. And I looked at him like, ooh, he's desatting. And so those arterial lines really give us a nice perspective on the airway, oxygenation, so on and so forth. And I called him back. I'm like, I need to give more O's. I need to blow off some CO2. Something's not right here. And he walked in, his little styrofoam cup of coffee. He goes, how long have you been doing this? I said, 6 months. Why? He goes, part of my lady manners, because they're going to go out the window. He's like, damn, you're good. Have you ever considered anesthesia?
So it brought you right back to anesthesia.
I was like, for a hot minute, I did. But here's the caveat to this, is that when I was in school at Chapel Hill, Dr. Neil Cheek, and I talked this to the very end about the acknowledgments. Dr. Neil Cheek, who was at the School of Nursing, had said to me, you need to take like biochemistry second level. And that biochemistry lab will teach you like diseases, like you can create hypertension in a test tube and diabetes in a test tube. Like, oh, this is cool. Melissa, I still remember doodling. That's how I remember things. I remember doodling in class about respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. And that figure, that chart is still in my head today.
Wow.
35 years later?
Yeah.
So I think we really find our purpose. Sometimes it takes a little bit longer, but that was kind of the start of it. And then, recovery room, then I went to home infusion, because I got F.A.C.T, which I really love. So I did some CPAP teaching and whatnot. But I was always intrigued by the reps and the OR. I'm like, this is cool. I want to do this. And I got my commission in the Air Force as a flight nurse. Very cool job. Most honorable job I've ever done. And I really learned a lot in flight school. So we talk about things on the ground and breathing. Wait till you get to altitude. It's a completely different animal. Even the way we calibrate our machines, like a suction machine, And then I found my way into the device world, pharma a little bit in 1997. So this
Okay.
whole thing, it's like through all the travels between the military, I was in Alabama, I was in Texas, I was in North Dakota, finally landed in Maryland as a travel nurse to finish my first master's. So that's how I got to Maryland
Okay.
and to start flying out of Andrews, which I did. But what was really interesting is I wanted to do this, and I saw an ad in the Washington Post for J&J for
Oh,
this
for
job,
another
and I
job. Yeah.
interviewed. Yeah.
Okay.
So that's kind of what got me back into it, was the pharma. And I did it for a couple years, but I'm just not meals on heels. I'm just not. And I needed more of a challenge. So I
So when
went,
you say, just to go back into it, so when you say it brought you back to pharma, what were you doing for pharma in that time?
yeah. So I worked for J&J. They launched a wound healing franchise. So I launched and sold Regranix, which was a growth factor, like a laboratory growth factor for diabetic foot
Okay.
ulcers. And
So
I did a lot of wound care with my infusion stuff. So that was really interesting.
wound care
Um,
is wound care is very interesting just in general about how the body naturally heals and how it wants to
yes.
reattach.
Yeah.
One thing I just want to bring up that I was most intrigued when I was doing my research on you, and again, I birds to a feather, right? They flock together. I was loved that you and I have one similarity that I really loved is I tend to love to work with companies that are creating products that are
Mhm.
creating streamline
Right.
consistency or bringing awareness to an industry. And
Mhm.
I saw that that has been something you have a pattern that you have done throughout multiple layers is that I saw what you did for intake, I've seen what you've done, which I find that to be such an incredible asset because having great clinicians, but
Mhm.
having great business people and understand how to
Mhm.
roll out a product, educate on a high level, because let's be honest, all sales is great education. And I thought I was
Yeah.
blown away by everything you've done from the educational sales implementation side of things. And I wanted to acknowledge that because I was like, she's really crushing it in that space.
I appreciate that. What's really interesting is so I was with J&J. So I had Regranix, the platelet-derived growth factor. I don't know where it is on the market now. I sold Ultram for pain and Levaquin. So I was in that,
Okay.
Levaquin. I can't remember. I just had a brain freeze for the other one, but the quinolone market. Hmm. And it kind of took me back to my infusion therapy days. And then out of the blue, the recruiter called and said, "Hey, how about this job with Roan Planck Roar?" I took a huge hit on this and said, "Okay, I'm going to dive on in." The drug was Sinercid, quinupristin, dalfopristin.
Okay, so
And
for the lays people out there, let us know what is that? What is it, and
yeah,
what is it for?
so quinupristin, dalfopristin is a really high level antibiotic. It's when
Okay,
vancomycin, or what we call Mississippi mud, but vancomycin doesn't work. So this was like the big gun. It was like $800 a vial. It was, expensive, but it was a last hope for a lot of patients with MRSA or methicillin resistant Staph aureus or VRE,
okay,
vancomycin resistant enterococcus.
okay.
So
So
we're talking
break
about
it
really,
down
really
even
sick
simpler.
patients.
Break it down. What would be something for my lays people that are not clinicians at all? What would that be like for people that are suffering with what?
These are people in the ICU with really,
Okay,
really, really bad infections, like a septic infection.
okay,
Your basic oral antibiotics don't work. Your basic like piperacillin, these basic antibiotics you would get IV don't work. You're in the
mm-hmm.
ICU. That was our target market, and you're very, very sick. Like you are literally on death's bed.
Okay,
Nothing in antibiotic therapy is going to work. And it was a huge jump because it wasn't even FDA approved.
mm.
And I was like, okay. And while we're in a meeting in Dallas, probably 3 months later, we finally got the FDA approval. And that's one thing in the airway world I really want to emphasize. There's FDA approved and there's
Yes,
FDA cleared. There's two
mm-hmm.
different animals. And this airway world is so big. You see sleep and breathing and all these knickknacks and biohacks and all these different things on the social media. And I honestly tell my patients when they come to me and say, "Well, I saw on the internet," I'm like, get off the internet. The internet will overwhelm you with so much information, it'll make your head spin. It'll cause its own anxiety. So get off the internet. Go to a
It's
trusted
interesting.
provider.
It's interesting you say real quick, because
Yeah.
the airway world, or however I want to put it. I mean, I almost want to coin it now, almost just airway aware, right? People just being more aware of how they breathe, why they breathe, and how impactful it is, and how much
Mhm.
sleep is correlated. It's interesting. I find it to be it's everywhere, but yet it's still so small. And there's so much ignorance when it comes to it. And maybe ignorance isn't the right word. Maybe that's a little harsh, but there's a lot of skepticism and there's like a lot of resistance
Mhm.
still
Mhm.
in some of this
Yeah.
space. So I love that you're bringing up the FDA and the science aspect and the implementation,
Yeah.
because I think that's an area we still struggle in a lot of ways.
Melissa, that is such a huge, and it really, it puts a bee in my bonnet, as they say in the South.
Mm,
It really frustrates me because I've worked in this pharma device world through, regulatory issues and compliance. We in the device world are regulated by the FDA. So let me break it down. FDA approved means, and it's usually for drugs because they
mm-hmm.
have to go through a clinical trial. So it's
Yeah.
showing safety, efficacy, and that it works. It's been tested on people and it works. Okay, so that's FDA approved, mainly medications. In the device world, there's FDA cleared, meaning it shows efficacy. Okay,
Mm-hmm.
and it shows safety. And when we break it down under FDA cleared, there's three categories: class one, class two, class three. Class one are a lot of your over the counter items like tongue blades,
Mm,
toothpaste, all these different things that are class one, like a nasal dilator, like the intake is a class one because it's kind of in a wellness kind of thing. Then we get into class two devices, which have to show that they work. So, like in my world, rhinomanometer,
mm-hmm.
acoustic rhinometer, peak nasal inspiratory flow meter. And then we get into class three, which are actual implantable devices, pacemakers, and things like that. And we're held to a standard. It's under, the jazzy term is 21 CFR. And 21 CFR really regulates what we can say, how we can say, what we can sell, what we can't sell. And there's a lot of things in the airway world that are happening that in the ENT world, we cringe. And I'm just going to call it out. Like, they're putting balloons in the noses. It's all over the internet. We're going to put a balloon in there. That's not FDA cleared. The device
Interesting.
isn't
Okay.
cleared. And they're taking an ear curette that's FDA cleared to put in the ear and putting it in the nose. That right there is an off-label use.
Hmm.
And then when you say, well, my product does this, so it'll help with PTSD and your sleep, those are product claims, and you have to be on point. I'll share a funny story with you.
Hold on,
So,
wait, real quick before you go there. I just wanted to bring a thing. Because one of the things with the ENT world that I find to be quite interesting is that a lot of the ENT world, when it comes to a lot of the things they prescribe or recommend, Flonase or whatever,
mhm,
it's
mhm,
very subjective on how the person. So it's like, hey, go use Flonase for 2 weeks. And then the person comes back and goes, do you feel any better? Like, it's a lot of subjective conversation
mhm,
in the ENT world. It's not like straight data of being like, oh, I can show there was a structural change or something like that. It is like
right.
this subjective conversation, right? Which I feel like in a lot of the airway space, that's some of the feedback we get, is that it's too subjective. Have you come across that or seen that when you're talking some of these device situations?
You are spot on.
Mm,
So, let me share the funny story with you, and then remember 8,000. Keep that in mind.
yeah.
So I was at Washington Hospital Center in 2006 with one of my favorite ENTs in the world. He was hilarious. I think he's still practicing. I don't know for sure. Dr. Pereira. Now, mind you, I was with Gyrus ENT beginning in June of 2003. And then I left in February of 2000. Oh gosh, 2007. Let me think. Yeah, February 2007. And then I went and worked for an ENT distributor up until the end of 2011. And then after that, I went and worked at Itamar and sold the WatchPAT. So
Yes.
I,
Uh-huh.
I'm in room 4 with one of my favorite ENT surgeons, and I'm selling a product called SepraGel.
Mm,
SepraGel is like a meltable, if that's even a word, a meltable nasal packing. Okay. So after your sinus surgery, they would put this little packing in and then it would just kind of dissolve away. Unlike like a Doyle splint, they actually put in your nose and suture there and they take out a week later. But I'm in the OR with Dr. P and his students and his residents and the fellow, and they're doing surgery. And he goes, okay, Karen, what do we do next? I said, we're going to use SepraGel. And I had my little sample. I was so excited, had my little sample. He said, what is SepraGel? I said, SepraGel is an absorbable packing with a carboxymethylcellulose base, just like our tissues. And he goes, what? Now, carboxymethylcellulose, fancy word for a sugar, okay? Mm-hmm. So he looked at me and he said, are you sure? And I said, yes. He said, are you sure it's absorbable? Yeah. He said, do you know who I am? I said, my favorite ENT to work with? He said, no, do you really know who I am? And I said, I give up. He said, I work for the FDA.
Oh, no.
that one word could shut your company down for false advertising and mislabeling of a product.
Wow.
What? He said, let me get this straight. Bone does not absorb packing. It's dissolvable packing. Okay. Yeah. So you can see when we're talking about these airway products, we have to be really careful about their claims. I said absorbable packing, and it was actually supposed to be dissolvable packing.
Yeah. One word makes such a big difference, and you have to be really careful. And I do love what you're saying here is that in the airway space, there are a lot of big claims, and I'd love to take this out. I get into this space, and a lot of the people that listen to that are, following us and lays people are these parents or these adults or these clinicians that have this understanding and acknowledgement that now they go, listen, this person is struggling to do a very basic function, and that is to breathe, right? Like they're breathing harder than they should have to. Their body, for me, I always say, right, breath is the gift of life. And just because you're walking this planet doesn't mean you're breathing well. You might just be breathing enough to feed your organs, and you're barely getting by. I almost feel like it's like a budget, right? And a lot of people are running on very low amount of oxygen. And I was listening to one of the podcasts you did, and I loved how you were saying that you can acknowledge how much the structure, the function, and the behavior really affects everything. And I believe in general that breathing is so connected to human behavior. And that's why most clinicians they don't know how to deal with it, because most clinicians don't know how to change human behavior. But one of the things I thought was great that you kept talking about is that you do a lot with being able to truly understand and dive deep in how one breathes, right? Is that not like with your product? Like I really was interested in that.
So I'm going to go back a little bit.
Okay.
And I talk about this in my book about breathing and breathing educating and whatnot. This isn't new science. I mean, look at all the women in labor. Lamaze. My mom was actually a baby nurse and taught childbirth education Lamaze classes. She taught women how to breathe during labor. So I think that this isn't a new phenomenon. No. I think what happened, and I did COVID research, I got pulled into this really cool way of, doing an over-the-counter concoction through a nasal spray delivery. And I told them, I said, it's only going to work if the nasal resistance is at that optimal level for that patient. Now, what's interesting is that, and going back to my 8,000, what does that mean? What's so great about 8,000? That's the number of cases I saw as a vendor in the OR during my time in the ENT world. I saw 8,000 cases in the OR in the office. And guess what? They were all subjective. The nose, the snot, 18, 17, 20, whatever year it was, or the update. Now, they're good tools. Don't get me wrong. I use them in my practice. That subjectivity really gives us insight to what the patient feels. We have to listen to what they feel, but we have to match the subjectivity with objectivity and how those two will measure up. For example, the MAVRIC, I can look at a face and just like that, know which side I will be seeing the highest level of resistance on. And I can see it in the posture, even the pronation of feet. I had a mom reach out to me and she said, my son breathes through his mouth. He's got pronation of his feet. Boom, red flag. Now, in my nurse practitioner program, I learned head to toe assessment, but I do a toe to head assessment. As soon as I look at your feet and I see offloaded on one side with a deviated septum contralaterally or to the other side, that tells me a lot. And that tells me this didn't happen overnight. We have to understand that, yes, we're not breathing well. I don't like that term. It makes me bananas. No disrespect to anybody. I don't like that phrase. Are you breathing well? Well, first of all, it's a closed-ended question, yes or no.
Yeah.
I like to say, how are you breathing efficiently? It's not a good or bad.
Is your body
it's
working?
A matter of efficiency.
Yeah.
And that efficiency is important on your particular physiology and your anatomy.
So, right. How much is the body compensating because of how your body is interpreting or breathing, right? So let me just for the people ask, what is a baseline of how do you determine how one is breathing?
So I use 4-phase rhinomanometry. I brought it to the US.
Break down. Do me a favor imagine, somebody that knows nothing. What is it? What is 4-phase? Break it down simple.
Yeah. So the concept has been around since 1894, 1895. It actually began with mirrors, like y'all use, looking at condensation when you breathe out. And over time, the technology grew and grew and grew. In 1965, Dr. Vaught, who is the actual father of computerized 4-phase rhinomanometry, he was an ENT, oromaxillofacial surgeon, and a dentist. And he was very frustrated with his ENT patients not knowing the surgical outcomes. He says, they all say, breathe well, woohoo. But he didn't really trust what they were saying. Not to disrespect the patient, but he felt that there was something else going on. So he created this rhinomanometry. There was a basic concept of rhinomanometry out there. And actually, Dr. Maurice Cottle, Cottle maneuver, he really brought 4-phase rhinomanometry to the forefront in rhinology back in the 70s. So he and Klaus knew each other. And then here's a quick stitch. From that, Klaus and Dr. Christian Guilleminault, who termed obstructive sleep apnea, became friends. Dr. Guilleminault was one of my customers. He used 4-phase rhinomanometry. So what is this fancy word? Well, I couldn't even say it in 2017 when I brought it here to the US commercially, expansively, okay? So I brought it here to the US and I couldn't even say the word. I was like, rhinomano, what is this thing? And at this time, in 2017, I'd already been in clinical practice for 25 years. Never saw it in the ENT world in those 8,000 cases. So I took a deep dive into this. And I asked the owner of the company, I said, well, what's normal? What is this thing? And how do we sell it? And I think it was in 2018, because at the time, the big push was structure, MRI, CBCT, acoustic rhinometry that has a little pulse sound wave that bounces off the structures that kind of tells you where there could be an obstruction, simple non-invasive test. But I went back to the owner and I said, y'all, we're doing this wrong. What? I said, we're doing this wrong. We need to look at nasal function, flow, pressure changes. And I want to correct some of the things that's out there. This little machine, it's a 15-second test. And it looks at 4 respiratory cycles. It's looking at 4 of your breaths. So each respiratory cycle has 4 phases, and that's where the term comes from. What drives our breathing is pressure, not the flow. Well, why is that? In our body, we have about 36 to 40 different pressures. My time in the ICU, I thrived on waveforms, and that's what rhinomanometry does. Now, on my website, I have all of my publications and podcasts and different, things that I've used where you can actually see what this graph. So it's a test that's 15 seconds and we clog one side of the nose.
Okay.
So we plug up the right side, we capture the flow on the left side, measure it against the pressure of the right to get the amount of resistance. And that inspiratory resistance really drives home your nasal function.
The resistance drives, let's break that down.
Yeah.
So the resistance drives the function.
Pressure drives the function. Resistance will dictate what you do as far as a treatment, progression, stability of that treatment. So people will say, oh, well, I'll ChatGPT the normal values. Don't do that. We have to remember when we go into ChatGPT and we say, what are the normal values? ChatGPT is looking at all the cumulative studies from years ago. And those studies focus on small populations. So if you were to go in and say, what's a normal nasal resistance? It's going to tell you 0.2 to 0.3. Well, that's wrong because I've really looked at this and studied this over the past 9 years. And there's about 253 variables that I come up with. Little things you wouldn't even think of. So we have to think of nasal resistance, that little biomarker, as your fingerprint. It's very unique. It's individualized to you based on different diseases, medications, where you live, your age. Are you perimenopause? Are you menopausal? There's so many different factors. So when we say we're breathing efficiently, we have to look at this from a holistic perspective, not just whole body, but whole environment.
Yes.
And
environment plays a huge issue. I mean, one of the things real quick, like my son who is 8, it's an ongoing struggle with him because he has severe allergies, is allergic to Bermuda grass. He plays a lot of soccer. And I heard you tell a story on a podcast about your own son playing baseball and that you could tell when he wasn't breathing right because of how he was actually performing. And it's the exact same thing with my son. And we've done expansion. We do all the things. And it's really hard. And it's because it's so environmental, right? And so, and I can see he's laboring to breathe. It's such an uphill battle.
Yeah. And I said that on my website too, that an inflamed nose is not a symptom. It's a signal. And that's why I created that 5th vital sign, that nasal resistance, because we breathe against resistance. And again, the driver of resistance is pressure, not flow.
So when you say these 5 things, like, so for a myofunctional therapist or, for a dentist or somebody who's trying to screen in the office, you know what I mean? Like I'm a big component that I think the number one thing we need more of in this country is screening, right? Like it's, we got to screen better. We need every dentist and every hygienist to be screening for dysfunction, right?
Right.
So, that's where it all starts. There's a lot of us that can and maybe do treatment, but we got to screen it. We got to educate it. We got to talk about it. And most people are walking around saying, oh, it's just allergies. It's common. They'll grow, or my favorite one, they'll grow out of it. Right? It's like, yeah, I know, grow out of it. No, they don't. They just compensate. They just create another issue. So when you think, what are your 5 main things or your main way of, if you get in front of a room and you tell people how to screen or at least start crossing the bridge, where do you go with that?
Yeah. And that's why I created the MAVRIC nasal exam, facial analysis, and posture.
Yes. Okay. So tell us about that. That was very interesting. Yeah.
So I created this whole proprietary thing under like F.A.C.T method. This whole thing, like everything in my head, I just put on paper and made it proprietary. And if I were in the front of a room, the first thing, and it's on my Instagram page as well, but the first thing I look at is the nose. That is the port of entry of all of our health. Now, some people will say, oh, the mouth. Well, the mouth will not work with inadequate nasal pressures. It just is. It is what it is. And just in our breathing capacity, we have about 8 to 10 pressures. We have interthoracic pressure, intracranial pressure, nasal pressure, pharyngeal pressure, oral pressure, interocular pressure. You can see interthoracic pressure. All of these different pressures have to work in sync. If one pressure is out of kilter, abnormal, the rest of them will it's a downstream effect. So I like to say that, another one of my terms that just really drives me crazy, if I can say that, sleep disordered breathing makes me bananas. Sleep does not disorder our breathing. Breathing disorders our sleep. But we have to understand, and this is where I kind of came up with this new term. If you want to stick with sleep disordered breathing, it's actually sleep disrupted breathing. There is a disruption in our breathing before there's a dysfunction, long before there's a disorder. This is a cumulative thing. And here's what I tell my parents. So if I were to say 5 things, and one thing I learned with my son that even a dentist didn't tell me, I thought I was doing the right thing. Take him to the dentist at 18 months, 2 years old, crunchy foods. He never really had those pouchy foods. Mama bears, please no pouchy foods. But he had carrots, cucumbers, nuts, things like that, apples, crunchy foods. And I made him chew, chew, chew.
So you were very ahead of that, not even knowing the importance of it. Just that was your natural instinct.
Yeah. I was just like, get everything just growing because, and in your world, the tongue is the strongest muscle, not connected to a bone end to end. So how do you work out that muscle? Through chewing, through swallowing. And I didn't even know what I was doing back then. But I always have, look at the nose, look at the nostrils. The nostrils will tell you more than you ever want to know. And this little skin right here in between your nostrils is called a columella. And if that columella is like to the right or to the left, right there, just 1 millimeter of difference will impact nasal flow, nasal pressures, and nasal resistance. It really does make a difference. And we want this, what we coin in our ENT airway lab is we look at partition to airflow. What is partition to airflow? Think of yourself as having 2 noses, 50% on this side, 50% on this side. When that begins to go into a 60-40, partition of airflow, we're okay with that. 70-30, cause for concern. 80-20, 90-10, that's just no. That's a no.
Yeah.
And so how do we get through all this? So
I just want to stay here for 1 second because this is a big thing that a lot of therapists, dentists that I really, I'm a big advocate. I kind of say this. I don't like when people ask, are you a mouth breather or are you this? Because it's not black or white. They make it this very direct this question. And I don't think that's the right way to do it. We actually, I teach with Sarah Hornsby, a lot of therapists. And the big thing is breathing is a scale. You have to be, right? It's going to fluctuate. And I think one of the biggest misperceptions or biggest concerns is that we will ask questions like, are you mouth breathing? Do you mouth breathe? We all mouth breathe a little bit, right? It just depends on how much and how often. And is it consistent? How much of it is it, behavior, form, and function? And I actually think that is an area that we really, really need more work on, is being more aware of teaching and educating people that breathing is a scale.
And it's a swinging pendulum at that.
Yes,
it really
absolutely.
Is. So to that end, look at the nostrils, look at the nose. The other thing is kids by 18 months usually have about 4 teeth.
Okay.
If you look at those 4 teeth, 2 on the top and 2 on the bottom, and there's no space, watch it. because that's where I failed my son. Is I thought his straight little teeth and all his preschool pictures were cute and normal. No, they were not that picket fence. But when you see teeth coming in, look to see if there was a space in there and watch that continuously as the child's teeth come in. That's a concerning red flag in my world. Okay. So I went back in Zach's pictures and looked at that, and even his first two teeth did not have a space between them. Yeah. So nostrils, teeth, and here's my big one, to your point. Mouth breathing. What's chronic? In the medical world, chronic is usually 6 months of ongoing issues. That's chronic. If it's less than 6 months, it's called.
So you're saying something that's chronic is consistent for 6 months?
Typically, yeah, in the medical world.
So what I love here, what you're talking about is you're starting to, again, between the teeth, the form, the function, the breathing, what's hard for me is that I guess my very simple question that I always want everyone to ask is, why is this such a hard concept for medical and dental to get in the room and have this conversation? I mean, you've spent your time nursing ICU in the traditional medical system. Why are medical doctors, dentists, why is it like we're talking to the Jews and the Christians? Why is it such, and I say to people, I go, I just had a conversation. I mean, I know my ortho and my dental people, why they don't bite in. And I know Dr. DeLuke had mentioned to you, sometimes it feels like an uphill battle because dentists don't want to really deal with the behavior of breathing. And then you have pediatricians that don't want to talk and acknowledge that the dysfunction in the mouth and the jaw are affecting the breathing. And they all want to say that enlarged tonsils and adenoids they're going to grow out of them or no big deal, just remove them. Why is this still why does it feel like you're beating your head against a wall sometimes?
Two ways. And one thing I wanted to share with parents or anyone else, we talk about chronic. I kind of came up with this definition. This is my opinion, not medical advice.
Okay.
But my opinion is sneak around the corner. Look at your child watching TV or doing homework. If you see 25% of the day with their mouth open for more than 3 months, watch it. 6 months, now that's chronic. And that 50% seems to be, if they're breathing in even 50% of the time, that's a really big red flag. We have to make this smart. How do we break this down into percentages to teach people? If you see your child breathing a fourth of the day with their mouth open, that's a problem. If it's half the day, that's really a big problem. We have to understand these breathing issues. Nasal resistance is very slow, very sneaky, very cumulative over time. It doesn't happen overnight. That adult with sleep apnea was the child that had a problem long before they had sleep apnea. The teen that's not performing in school or athletics had that problem before then. Yeah. So what is the problem?
Yeah.
You want to know the problem?
Perfect example. I have this kid who's had expansion, a tongue tie release. We've done allergy shots. We've done everything. But he's a chronic mouth breather because he cannot breathe through his nose nonstop. And I do saline rinses and I do all those things. How do you overcome? Because breathing issue is like mold. And it's a big issue for a lot of people. I mean, you can't, it doesn't matter how much expansion I do. It doesn't matter. I mean, I do cranial sacral on him, everything. And I'm almost saying this because I know there's a lot of therapists and moms out there. I have a lot of patients and clients that have said to me, Melissa, I did all the things and he's still struggling to breathe.
I'll tell you this, like I said in my webpage, an inflamed nose is not a symptom. It is a signal. Now, I'm going to answer your question about medical dental and then remember gut nose. Okay. So I don't know what it is. A lot of us are type A in this field. Medical dental, we're type A. And we're very territorial. We love our patients. We don't want them to wander away like little ducklings. We want to keep them, in our little cove. Interestingly enough, when I sold the WatchPAT and we were in the dental market,
So for
Back in
anyone that doesn't know what WatchPAT is, that is an at-home sleep test.
Yes, and you wear it on the
Yeah.
wrist. It's got the little probe on your finger.
And right now, with WatchPAT, I think right now, right, because there's a big thing is like, can you do at-home sleep studies on your children?
Yes, I think they do have a pediatric indication. Now, I was with them 2012, 13, and 14.
Oh, okay.
Yeah. But back in 2012, what's that, 14 years ago,
Yeah.
I was trying to promote ENT, sleep, and dentistry, this little Venn diagram, this little trilogy of care in the sleep world. What's really interesting, Melissa, is that it was just like this. It was like having 3 kids and trying to make them share a toy.
Mm-hmm.
It was crazy. It was like, no, it's this, no, it's that. And I feel like in the dental world, because of that territorial, dispute back in 2012, 2013, 2011, all that time way back in the day. And even in the OR, we did all these different sleep surgeries. And in my time in the ENT world, nobody talked about a dentist when we're doing sleep apnea surgeries, UPPs, tonsils out, adenoids out, tongue-based procedures. No one ever mentioned a dentist back in, 2003 to 2011. Never heard of it. And then I get into the sleep
you're
world.
saying that in the sleep world, they were doing all kinds of soft tissue procedures, all kinds of stuff on that, but no one was talking about the dentist or creating space or talking about enlarging the upper maxilla or the mandible or anything like along those lines.
Yeah. Mm-hmm. And that, like I said, that was from 2003 to 2011. So you can kind of see how this has transitioned over the years. And then things became territorial after 2010. And I think just based on my observation, and I probably will not make friends saying this, but the airway market is so big that everybody all of a sudden is an expert. You've got people taking a weekend course.
The airway wave.
Yeah, they're like, I'm a, and don't get me wrong, but they're like, well, I am, trained in this, in airway. Just because you take a weekend course does not validate that expertise. And I think the market is so big that everybody wants a piece of it. That's fine. But I think we have to put things into perspective. And when I have parents that call me, well, this orthodontist said this. And then I went and saw this orthodontist, they said this. And another one said this. And they call me frustrated. Karen, what do I do? What does your gut tell you? What does your heart tell you? You know your child better than any practitioner in this world. And you have to fight for that child.
Yeah.
And I had to do that with Zach. I'm not going to leave a room until you answer my questions. And that's why I like it when parents, before I see them, I always ask them, journal your experience. Tell me your story.
That you're saying that.
Yeah.
I love that you're saying that.
Tell me your story so I can better understand before you walk in my office or before you get on Zoom. Tell me your story. And I just had this yesterday. I was pulled in with a UK provider. Like I said, hey, at the nose, well, it's underscore the nose. Chime in on here. What do you think? And my first question was, how old, how long, any trauma to the nose?
Let's just so we can break this down, because this is really interesting stuff. Okay, so trauma can be physical trauma. Can it also be environmental trauma, like just stressors in the household?
Yeah, I mean, Melissa, think about this. We have little cilia that move things along. We have millions of mechanical receptors in our nose that go from the olfactory nerve, the smelling nerve, right to our brain. There are 2 nerves, the optic and the olfactory nerve, that go right to the brain sending signals. So if you've got mold issues, allergies, those cilia, they're not working well. They're not picking up the scents. They're not picking up the sensory of the air. And that's really important because, how the velocity of airflow or the speed, how much of airflow is all being detected by these little tiny receptors in our nose. If they can't pick this up, they're not sending signals to the brain. Now, I want to remember the gut. So I create this little phenomenon, or another medical term. I get these crazy thoughts in the middle of the night that literally keep me up at night. So I coined this little term, the gut-nose axis. And what does that mean? When I was seeing
I am so intrigued by this. Yeah.
when I was seeing a patient, left deviated septum. So because that side was smaller, kind of leaning over, taking the load, this is part of MAVRIC, but taking the load off of that right side, and they had an ankle injury. Makes sense. Tonsils out, adenoids out, sleep study done, saw a dentist, had an appliance, but still had problems. So I'm going through the past medical history, PMH, which we'll hear. And I'm going through, medications, herbs, supplements. And I went down and I said, well, looky here, Crohn's disease. And I said, is your Crohn's disease stable? Nope. I just started a new medication. So right there, an inflamed nose is a sign of inflammation in the body. The nose feeds off of the gut, no pun intended, but the nose feeds off of the gut. Gut issues, congested nose. Remember, that's a signal. Your point about the nervous system.
Yes.
The nervous system feeds off of the nose. So the brain, or think the brain's a switchboard. No, the nervous system feeds off of the nose. High resistance, remember, at each level of nasal resistance, something physiologically happens to us. When I do a rhinomanometry test and I look at the waveforms, again, ICU nurse steps in and I look at these waveforms, that tells me how consistent the breathing pattern is. And when I see what I see, I can tell when anxiety is kicking in.
So let's just say real quick. So let me talk about kids. So a lot of these kiddos and adults that have these big allergies, right? Especially kiddos. I notice that they all also have picky eating. They have struggles. I always talked up to is that there's a lot of mucus in their mouth, the texture, soft palate dysfunction, but they have gut issues hand in hand, especially when they're in an acute sinus buildup or an allergy flare up. The last thing they want to do is eat good food.
Exactly. So remember this. We smell our food when we inhale. We taste our food when we exhale. Now, I talk about this in book number 2. I think it's part number 5. I think it's part number 5. So book number 2, The Nose Decoded. And I'll tell you that story. It's a kind of a funny story. I talk about this. We smell when we breathe in, and we taste when we breathe out. That child that has picky eating can't taste. There's something going on expiratory wise, meaning when they breathe out, they're breathing through their mouth. They're missing all of the action in the nose to pick up these senses.
Wow.
So, and it could also be if it is a gut issue, and it could be a virus, a stomach virus. It could be microbiome, not my area of expertise. All I know is the gut will talk to the nose. We have to look at these different things. Irritable bowel syndrome, all these different gut issues. And Melissa, that's why I really, really want to get out of this box. You had said medical dental. We're so territorial. Everybody wants to be the expert.
Everybody wants to be the expert. Well, everybody, let's also, it's like, there's a part of us that you've been obviously in this space a long time. There is a part that, we've had to fight for this too, right? Like I speak to a lot of colleagues and, like you said, I've also been told I was nuts or crazy because like you drank the Kool-Aid or you died, you went in because it's a lot easier just to do medicine the other way, write a prescription, write a pill, go home and just stay in the status quo, right? Like
reactive medicine. We react to the problem.
Yes. And I'm living down south right now, and you would ask that. And the thing here that I don't it's a little tricky is that life is very simple. Like, people are very kind. They do the right thing. You said you're a Southerner from heart, but they also don't love when you upset the apple cart that much, right? Like don't fix something if it ain't broke. And I've been told that people are like, well, like I had an orthodontist say to me the other day, like, I want to just do the teeth. I'm not saying the breathing thing is an issue, but I don't know if
Mhm.
I can fix it. And then told us that we're over treating. Oh, if you expand a young kid, the teeth are going to relapse. And I said, well, what if it's not about the teeth? I said, what if it's about the breathing? He goes, well, I mean, I don't know. Is it really going to make a difference? And those are tough questions because, like, when you have a kiddo like mine, you might not see the difference. I mean, there's a lot of things. I know the expansion was a big part of it, but his breathing is still, I still have a long thing. And a lot of parents don't have patience for that. They want it fixed yesterday.
Well, that's because we're a society of instant gratification.
Yes. Oh, isn't
We,
that the facts?
we want an answer now. We want a solution now, 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 now. I mean, how many times do you have a patient call like, well, what's the status?
Yeah.
When I'm working with some of the doctors, like, did you get that test? Did you do the test interpretation yet? I'm like, I'm getting there. Yeah, I mean, we're a society of instant gratification. We want everything now. We want weight loss now. We want to be skinny tomorrow. It doesn't work that way. We want to breathe tomorrow. That's why I said this is cumulative. If it took you 5 years to get here, it'll probably take you 7 or 10 to get back to where you were.
That is true. Patience is definitely not the game that anybody's in anymore because we're so used to getting everything, Uber Eat or whatever it is. We get it within seconds. Tell us your tool. I can't even pronounce it. Say it for me again. The
Rhinomanometer.
Rhinomanometer.
You did it.
Yes. Is that something that a myofunctional therapist can purchase? Is it only doctors? Who uses it and where does one find a clinician that has it?
So let's go backwards. So I know where I sold them. A majority are medical and dental. It's really tricky because this is a class 2 device. So we have to look at scope of practice. Are you able to put something in the nose? It's state dependent. For example, like some states you can't even spray an over-the-counter spray in someone's nose, depending on your license.
Okay.
So you have to really look at that. Now, what's interesting is that back in 2017, when I was doing part of my doctoral defense and research, speech language pathologist, I was looking at the billing code of 92512 as far as reimbursement. Speech language pathologist in the Palmetto GBA had a modifier so they could do acoustic rhinometry test, because the acoustic rhinometry test was a little nose piece that sits on the nose, doesn't go in the nose.
It sits on the outside of the nose.
Yeah. So it just just sits there. But the foam for rhinomanometry goes in the nose, and there's a tape method where there's like a little divot that tapes to the nose. So it's really tricky on what you're doing and how you're doing and what your license allows you to do based on your state board. But overall, generally, nurse practitioners, like I'm an airway clinical nurse specialist, so I have one in my office.
So you're an airway specialist, but nurse practitioner. So you have one in your office. Your license allows you to do that.
No, I'm an
dentists. Some dentists in certain states can do it depending on what the state allows them to do, depending on where it can go in the nose.
Yeah, so I'm an airway clinical nurse specialist. No, I'm not. I started a nurse practitioner program. I'm like, I don't want to work in a clinic all day. Sorry, I love my nurse practitioners, but medical folks and dental folks. Here's the catch, because it comes down to diagnosing nasal resistance. Can you actually diagnose nasal resistance? And can you create a plan that acts on that? So it's really a big gray area. Now, I'm licensed in 44 states and territories because I'm part of the Compact Licensure Act. So in my world, it's not a medical diagnosis. I would say that it is a inefficient airway or inefficient breathing patterns or inefficient sleep patterns. And then I send them off to an ENT or orthodontist to have CBCT done or get the actual exam with the scope up the nose. And that's one thing, Melissa, I'm really strict on. Okay. What I've seen over the past 9 years is with expansion. So I had this situation and it was a rhinomanometer tracing, and I looked at it, I just wasn't comfortable. Now, I covered Children's National Medical Center, and during that time, we don't do elective sinus surgeries in kids under 18, minimal 16. And usually there's some things, and that's an ENT world. So we have to remember that their sinuses are still forming, and the turbinates will still grow up to their 19 to 21 years old.
Oh, that's important to know. Because right now, right, and I only can talk in this, is like I have this, my little guy, sinuses completely filled with junk. I mean, like top, and doesn't matter what we do. And I had one ENT say to me, do we go in and maybe try to break it up a little bit? And then half of them were like, do not do any procedure. He's only 8 or 9. Like, he's growing too much. It's tough though, when you like, don't know what to do.
Like, what? Is there another spectrum? I had one of my friend's daughters who was 17, and I said, oh, go see one of my favorite guys up in Annapolis. Really good. And he said, you tell her she knows I don't do any procedures on kids under 18. I'm like, ooh. And all it was a nasal valve issue. But
so it does really kind of depend. Yeah, it really does depend on the doctor.
Yeah, and even in the countries, some countries say, yeah, we do sinus surgery in kids. But I know in my world here, I only saw them after like 12 weeks of failed medical therapy that they would do something. Or if there was an actual structural issue from a birth trauma or an actual physical trauma, a sports trauma, something like that. That's a different story. Like one of my neighbors had her daughter was a cheerleader and had a broken nose and said, who would you go to? And so in that case, they did. So it's a really gray area.
And I think that's one thing about this space is that there isn't a direct, clear line of treatment for everybody. It really does depend. I mean, I have patients that have had orthodontic expansion, great myofunctional therapy, and just started doing nasal hygiene, and it made all the difference in the world.
Yeah.
And then I have others that have done expansion, myofunctional therapy. They've done different breathing aspects, and it hasn't made that much of a difference at all. Like, you know what I mean? They're still snoring a little bit. And that's where I think we really talk. I love the gut conversation because one of the things for me, and as you had said, is that there's just so many other aspects of, how anxious is somebody? Right. Do they live in an anxious household? What are the variables that we aren't aware of or that we don't want to talk about that really can also be creating a big issue on the cadence in which someone breathes?
And to your point, I think we really have to listen to what we're saying. When you're on social media, and no disrespect, but all these dentists are about ADHD, and it's an airway problem. Not always. It could be a dopamine problem. We can't hang our hat that everything is an airway problem. It can be a contributing factor, but that's where, after working in children's mental health in the mid-90s, we didn't look at airways. Everyone got a pill. That's another conversation for another time because I get really passionate about it.
No, listen, I don't know if you saw my story. I don't know if you saw, that was my biggest thing was I was put on Adderall when I was 18, 19. I'm an 81 baby. My brother was put on when he was in 3rd grade. And I'll tell you, I'm not saying that we both had dopamine issues and the Adderall helped to a point, but it also did really affect me on a lot of other ways. My clenching got worse. My grinding got worse. There was a lot of side effects to that medication. I'm not saying it didn't also help in some areas, but those were things that I couldn't calm my central nervous system down. My breathing got way shallower when I was on that, when I was on Adderall. And it took me years to come off of it. And it's taken me all my 40s to rebuild a toolbox to try to navigate it. Yes, I have dopamine issues. I have, focusing issues. And I can see when my son can't breathe and when he doesn't feel comfortable in his own skin, he wants to go on the iPad. If he's on the iPad too much,
Right.
then all of a sudden he can't focus. He can't calm himself down. You know, he's all of these different traits and characteristics, and not taking that away from any parent that's just trying to survive and get their kid through school and do all the things. You need help. But all I know is this: if you don't sleep well, you don't perform well. But if you don't breathe well, you can't perform well, and then therefore you're going to have sleep. You're not going to sleep well.
Well, remember,
and it becomes a hamster
Mike DeLuke.
cycle.
We need to breathe well to sleep well. We need to sleep well to perform well. I think that this is the opportunity to really bring in the mental health aspect. Now, if you looked on my page and you looked at those CDC stats, children ages 4 to 17, I think there was 5.3 million children diagnosed with ADHD. And of that,
how many kids are diagnosed?
5.3 million. And
5.3 million kids are diagnosed with ADD.
And that could change. Look at the CDC stats. I think it was, is it 5.3 million? I think that's what the number is. But 69% of those kids are on medication. Now, last Labor Day weekend, I went completely bananas. There was a study that came out from Stanford University, it was published, and they were finding that children ages 3 to 5 years old were being put on medication 30 days after a diagnosis. Now, here's the problem, and I say this from experience. When you put a label, aka a diagnosis, on a child about ADHD, that stays with them. It stays with them in school. It stays with them in college. It could stay with them through wanting to get a job, like a pilot. So we have to be really careful with this. And this is where we can't overdiagnose, but we also can't underdiagnose. We got to pull in our mental health folks. Dentists can't diagnose ADHD. ADHD is not a symptom. It is a diagnosis. It's a medical diagnosis that goes through a lot of testing. And one thing that came about in 2009, I think it is, it's called the Vanderbilt assessment tool. And we use them in schools.
Can I just go back on something? You say that there's a lot of testing for ADD and ADHD, and I'm not denying that there is for kids. But I will tell you that when I was in my 30s and I went to a psychiatrist, okay, because I had come off of the Adderall and then I wanted to go back on and whatever else. And she said, well, when's the last time you've got tested? And I said, I don't know if I ever, in the 80s, I don't remember. Maybe I met and talked to a counselor or something, but I don't remember going through a rigorous. Yeah. And let me tell you something. And when I was in my 30s, I sat down, they gave me like 25 questions. And it was like, do you focus? Is it hard to pay attention? Do you get frustrated easily? Ding, 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 ding. I just hit yes, yes, yes. And then I walked in there and she's like, here's 40 milligrams of Lexapro and here's 40 milligrams of Adderall.
That is so wrong.
So do you know what I was like? Yeah, I don't even know. I mean, I don't say this, but I feel like even some of the testing is interesting across the board. I am not an expert in the testing and maybe I should, but I'll tell you, my anxiety was through the roof. I didn't have any tools to manage my anxiety. Yeah. All I could rely on was substances. You know what I mean? It took me really, and if it wasn't for my path in airway and realizing that my own cadence of breath was so short and flat, because I talk fast, I'm overly thinking, all these things, right? I used to just think it was because I was from New Jersey and I'm from the Northeast and that's just the way we do things.
I'm just a happy person. I just love what I do.
Or, my mind goes so fast. I eat fast. I do all these things fast. But really, it was because I was in fight or flight. I didn't even know how to just be in my own body.
Melissa? I think, my own opinion, I think we are all in a state of fight or flight. Look at our world. We are all impacted or triggered by something that throws us into overdrive. I mean, it could be so simple as, a dog barking in the middle of the night, like mine was at 3 a.m. And I'm like, no. It could be a world situation. We have to understand that people are people and people are individuals, and we have to understand what's triggering that chaos in their mind. And I think that's that mental health component that not a lot of people are talking about. It used to be kind of taboo, like, oh, you have depression. A mental health diagnosis is not taboo. It's recognizing and being aware of what you have. Here's an example. PTSD. 75% of us in the military have some level of PTSD. I saw some things that would make some people cringe. Very sad. And
I think people have PTSD before they even go into the military.
It might, and then it gets exacerbated. But, I think we all have, because in my world, I was taught to not feel. And I know it sounds harsh. And I've turned ventilators off on patients and literally have watched them die. I've seen the first breath when I was in the NICU for a short time. I've seen the last breath when I did hospice for a short time. When I was in, an infusion nurse, they'd pull us over to hospice. And I've had a lot of hands coming back over from Europe as they transition and as they're stable for flight from Germany to the US. I've had a lot of hands. I've seen a lot of bad stuff. And I think that our experiences are embedded in our minds that impact the way we react, the way we respond, that downstream affects our nervous system and breathing.
Wow.
And our sleep. And it's not bad to talk about it, y'all. It's not bad to talk. It's very healthy. It's very healthy to talk about it.
Well, it's important to talk about that the best gift we all have is our breath, right? It's an absolute fantastic tool, right? It's the tool. It's truly the gift of life. What you just said, you've been able to, as a nurse and you've probably seen people come in and take their first breath and you've seen people take their last breaths, right? I mean, it is ultimately what keeps this beautiful monkey soup moving. Right?
I would say Genesis 2:7, we were given the breath of life through our nostrils.
Yes, I mean,
biblical.
The ability to take a deep breath is fascinating. It's so powerful.
I think we need to harness it in. I think we really have to look at our sources of information. It goes back to FDA-cleared, FDA-approved. Is what you're doing, has it been tested for safety? Has it been tested for efficacy? The market is flooded. And I always ask people, just do your homework. Stay off the internet, but do your cognizant homework. What is your source of information? Is it a licensed person from an accredited university program who's giving you information? Now, on social media, you have to say, oh, I can't give medical advice. But when you look at the influencers, and this is scary, 33% of, is it Gen Zers? I don't know.
Oh, yeah.
These young kids, 33% of young kids get their medical advice off of TikTok. What does that tell you?
Yes. Well, but it also shows the fact that they don't trust. There's two parts of look at it. Is the problem is that the reason why people go to social media and do things is because they want to be able. What I have resonated in, I think people do want to have different conversations. People want to hear things from different perspective, and I think it's an opportunity for the medical community and the dental community to go a little bit outside so that they can meet people where they're at instead of saying, no, it has to be one way or another. Right. So to only say, oh, no, this is the way it is. And this is the way it's always been done. I think that's a bit ancient. And I do want to say with these younger generations, Gen Z, Gen X, Gen Alpha, they are absolutely holding us to a different standard. They want more information and they don't want to be said, oh, it's that way and only that way. So, as much as there's things I don't love about them, I do love that aspect of these generations. But you are right. You can't just take everything for TikTok. But I think if you see patterns and you see trends and you see something consistent, I don't think it's right for the medical community to dismiss those patterns and trends.
Oh, I agree. And I think, and I talk about this in book number 1, when we look at educating the population in the 1970s, it was in the 1960s, it was the doctor was the authoritarian figure. Do as I say and do as I say. Then it
Yes.
transitioned into the 80s where we started beginning to look at people as people in healthcare. And then in the 2000s, we started transitioning, maybe the 90s. Let me think, in my nursing school time. Yeah. In my nursing school time, I had to start looking at culture and looking at people's cultures and what influences them to do what they do, whether drink, overeat, or whatever. We had to look at people and their cultures. And it was around the 1980s when we started having patients really be involved in their plan of care. Now it's kind of swinging the other way where patients will say, I want this, and I want this. And I've had that happen. And I've had providers come back to me and say, what did you send me? Because they came in and told me what I was going to do. And I'm like, whoa.
I just had a provider call me and tell me that they're not going to just do things because the patient is bullying them into doing it. And I said, and I agree with that. But then the question comes down to some of these providers is that, are you at least hearing what the majority is at? Like that there is a different way of looking at it and you're still trying to fit everybody into the same box.
Melissa, that's so funny you say that. Not funny, but ironic. Because I just had this conversation with somebody, I can't remember who it was. I just had this conversation with somebody and we're talking about oral appliances and devices. The industry has a huge influence on providers. And you get these providers that go, well, I'm going to go to this program with this company and only use their devices. And I'm like, that's like me saying in my infusion days, breast cancer, I'm only going to give you 5-FU methotrexate. That's all you get. That's it. That's going to be your little cocktail for your oncology. That's just so wrong. And I think that, when a lot of the doctors are influenced by a lot of these companies, and that's what be really careful of industry influencing physicians, because then we get into the other conversations with the Sunshine Act and the anti-kickback statutes and all these other different things, which the public needs to know that companies have to report to Medicare and Medicaid who they are paying. And
yes, so this is a very important conversation. But here's where it comes down to. The reason why so many of these providers that get into this space will rely on whatever a company or a product tells them, that's because of academia. That is because every dental school will not come up with a plan of action of teaching these providers on how to address and treat and truly design a proper approach for sleep disorder, like for dental arches that are not developing or there is a lot of side effects of breathing issues. Because one of the things in dental, ortho is my background. That's like where I grew up. Like that's my home. Before I went to hygiene, I started in ortho. I love orthodontics. I love orthodontists, but very engineering mindset, cause and effect. And again, they went to school, they learned this, very detailed way, but they are taught, as far as I know, and please, if I'm wrong, I'm sure somebody will correct me, but they are taught to treat to the dentition, to class 1 occlusion, right? Ideally, this is one thing Dr. DeLuke and he's been getting, is make that bite look like a class 1 occlusion bite. And that is aesthetically what they are all, and they will create that bite sometimes, in my opinion, at all costs. And one of the things that I don't understand is that they'll say, oh yes, orthodontics can help sleep apnea, but we can't do anything to create sleep apnea. I just don't understand that concept, because if you can help something, there's always good and bad on both. You always have the variable that you also could make something worse. I mean, you don't get it both ways.
You are absolutely right. So I'm going to chime in on that because I coined this little term called pseudo UARS. So I had this very world-renowned orthodontist who sent me a case. It was not identifying information, and it's HIPAA compliant, but he was so excited. He goes, look, KPD. Now that's a nickname, KPD, because Karen Parker Davidson was just too much to say. So one of my ENT surgeons gave me the nickname KPD. He said, KPD, look, I went from 19 millimeters to 23 millimeters. So, and he said, so, what do you mean so? And I said, I don't care about intermolar width. I don't care about, the degrees of change in the nose. I care about what you've done to that pressure that's going to dictate flow to get to the lungs. And I said, he's like, well, the patient's having problems. Pseudo UARS? He goes, what the heck is pseudo UARS? I don't know. I made it up. But let me give you my definition. And here's the definition, is that expand, expand, expand. And what you've done is you've created good sleep, created good breathing, but you kept expanding. Now that little pressure, think of a little red ball in your nose. Okay. And that pressure gradient in your nose has kind of gone downstream a little more to now the nose looks good, but the pressure differentials and changes are not. Now they clinically present as upper airway resistance. The nose looks good, but that pressure differential has gone downstream. And in 1974, at the third annual rhinology meeting, they presented this and said, my nose is bigger, but I can't breathe better. Why? Pressure flow relationships.
Pressure. Yes.
So that's why I pioneered flow-based expansion, flow-based orthodontics, and flow-based dentistry, monitoring the changes with 4-phase rhinomanometry. And I work with dentists who say, hey, can you measure this person? Sure, I can do that. Hey, will you do an interpretation for me? Sure. You test, I'll interpret, and I'll tell you. Stop, go, wait, stay, whatever you need to do with that expansion, because we're all different. Remember, we all have our own little individualized nasal resistance level that helps us function.
We all have, it's all individualized.
Yes. And that's why I think we have to listen to the story and remember that person is a person. And
everybody has their own. I like that. Everybody does have their own, own story, their own journey.
Yeah.
So, okay. So your goal, or what you have copyrighted and created, is a protocol and a prototype in a way, which you can work with. Am I correct here? Right. With expansion, breathing cadence, therapy, all the things. And that's what you teach on too, correct?
And even with myofunctional therapy, it's really interesting because, I was working with a dentist on Saturday, and I said, this is a great tool for myofunctional therapy. Do you need...
Yes, please give us tools. We love tools.
Do you need to do a tongue tie release? Now, I know there's a lot of hoopla over the past year from what I could see, just on social media and whatnot. Not my area of expertise, but what is my area of expertise is a floppy tongue that's on the back of the throat. Yeah. Please.
Okay. So let me explain what, and I'd love to, and actually what the team wanted me to ask you this, that they want, so I teach an advanced myofunctional course, and I teach it based around orthodontic expansion, right? They call me the ortho myo girl.
Oh, very cool.
I just did a social media post that I said, it's really not about the tongue. And we at Faceology had changed the concept. Tongue tie means nothing to me. When I do an exam or I look at somebody, I'm looking at dysfunction. I'm looking at their breathing cadence. I'm listening to how they speak. I'm listening to how much air is getting trapped behind the back of their throat. And I'm looking at compensation of that whole body, right? Really looking at how the body's functioning. Yes. Everybody in my mind, and you tell me this, right? We all have a restricted tethered tissue. Everybody has it, whether it's grade 1, 2, 3, or 4. The question is, after good myo, good breathing retraining, and really learning how the issues in your tissues and how your body's moving, we then at that point, after 8, 12, 14 weeks, 6 months of some type of protocol, we revisit. Is the restriction possibly creating a pull or a tether that is contributing to the tongue falling into the back of the throat? We have really gotten away from the fact that the tongue tie is the culprit or anything like that, because I think after 2016, everybody made it about the tongue because it was the new fad. And again, I think that's very medical, right? Like everybody wants a quick fix. So the tongue tie just made sense to providers because it was like I could go in, use my laser, pop this tongue open, but we saw that it would create more issues. It didn't fix anything. Is that correct? I mean, is that a better way of looking at it? We're really trying to recognize that the tongue is just one part of it.
Can I get an amen?
Yes, okay. I'm glad because I think we, and I think tongue ties just became a fad. I don't like the word fad because they are an important part of the puzzle. Yeah. They're just not the entire puzzle.
So let me explain from my perspective. Okay. We are negative pressure breathers. And I'm working with a sleep center and they're like, we're working the myofunctional therapy. I'm like, yes, don't clip the tongue. We have frenulum throughout our entire body. Okay.
Yeah. We have fascia all the way down to our toes.
And if you clip that frenulum, what happens to an organ? It drops. I mean, it does crazy things. We're negative pressure breathers. And you can do a release and still have an unstable tongue. And no amount of myofunctional therapy is going to rectify that when there's comorbid issues or additional issues. Here's an example. There was an adolescent that was in a device and I get the rhinomanometry reading. I'm like, oh, that's what I coined crazy tongue. What the heck is crazy tongue, Karen Davidson? Crazy tongue is a tongue that has had a tongue tie release, not compliant with myofunctional therapy or no myofunctional therapy, or didn't even need the release, but upon inspiration, and I can see it on the 4-phase rhinomanometer, upon inspiration, the negative pressure pulls the tongue back into the throat, disrupts the retroglossal, retropalatal pressures that goes right back to the nose. Again, pressure driven against the flow, creating higher resistance. And this crazy loop where the air is trying to get around that tongue. It's wild to see. I need to do a reel on that and actually show what it looks like. But when I see that, I'm like, whoa. The other thing too is that what about a nasal valve issue? We can see a nasal valve collapse, but what we can't see is a nasal valve phenomenon. And this was discovered back in 2014 by Dr. Vaught. He thought it was an operator error. Like, what's this crazy loop thing? And now there's people out there trying to teach rhinomanometry and they're like, oh, there's a loop. It's a nasal valve phenomenon. No, there's more to it than that. You have to look at what phase, 4-phase, what phase of the 4 phases that it's happening at, and does the loop match the data? And that's the missing key point. But to your point, do I think every tongue needs to be released? No. It could do more damage than good. So do everything you can, strengthen, flexible, not my ever expertise, but whatever you do, and then go back and evaluate.
Yes.
What's that thing you measure the tongue strength with? OPA? What is it?
Oh, yeah. The OPA, the device that shows whether or not the back of the tongue is getting stronger.
Yeah, I mean, all your diagnostic and measuring tools that you use, look at that, and then go back and reevaluate. But I'm here for you.
The easiest thing to do is you don't even need some of those fancy tools. You just need to know how much is that lower mandible no longer having to support the weakness of the mid-tongue, right?
Yeah.
The thing about the tongue to me is the tongue mirrors the abdomen, right? Your tongue is like, if you have a weak core, you have a weak tongue, you're going to compensate all day, every day. You're going to use your lower back. You're going to use your knees. You're going to use your hips.
Let me let that marinate for a minute. Say that again. That's interesting.
Yeah. Your tongue mirrors your abdomen. So, right, with our abs, our core, the core of our body is crucial to what? How we bend over, how we hold ourselves, our hip flexors, all that aspect. And when you have a weak, and think about it, think about the abs, the lower abs, the side abs, the upper abs, right? All of these different muscle groups will depend on where you compensate, where you lean, your posture, how you breathe, how you present. Your tongue is identical, right? If you have low lateral borders, like really weak obliques, right? What are you going to do? You're going to use different parts to push off and try to hold. Right. If you have, weak, and we compensate. Some people have stronger abs, but think about your lower back or how you bend over. If your tongue is weak, your mandible gets overused just like your lower back and your knees. And think about our
Yeah.
TMJ condyles, they mirror our hips.
The hips don't lie.
Your hips don't lie, neither do your TMJ condyles. And one of the things you had said that I loved was I think I heard you say this. It starts with dysfunction before it becomes a like a problem. Am I correct?
You have a disruption before a dysfunction, before a disorder.
Yes.
So disruption.
A disorder. So think about it. If you have a lower mandible issue where you're overcompensating, that will be a disorder. Then you'll start to click a little bit. That's a dysfunction. Then you wear down your condyles and now you have a disorder.
Bingo.
So it's exactly the same thing, right? The body, right? Everything. Anatomy 101.
Yeah.
Muscles win every day.
Exactly. Yeah.
And the number one thing of anything, and I think go right back to our beginning conversation, is that the ability to breathe. And I think when we were talking about, I think what you said, your mother, whatever, with Lamaze, the ability to breathe through one of the most intense times of a female's body, going through, bringing in another life. And the number one thing that we were teaching people was how to use the gift that they were given, and that is their breath.
Yeah.
And I think the number one aspect to come full circle on this is that I do think in general, most people assume that they are just breathing, just because they're alive, they're breathing. And I think between your work, your books, and the things you've done, you are able to highlight that breathing there's so many little nuances to it. It's a craft, it's an art. And I think it's something, if we all spent a little bit more time focusing on, we could really, I don't want to use the word heal, but we could kind of take back power a little bit in our own health.
And it's interesting you say that, because the airway world, there's a bazillion breathing instructors and coaches and whatnot. I don't want to be in that sleep and airway world, sleep and breathing world. Mm-hmm. I want to be different. And that's why when you look at my homepage, I scroll down. Sleep and breathing is all over the market. I mean, it's a bazillion-dollar market. I want to be different. And that's why my platform has been nasal function, nasal resistance, because that's the driving forces and biomarkers to breathing and sleep and our own physiology. I love what you said about the tongue and the gut and the core. I was just telling my one girlfriend last night, I said, because I'll be 61 this year. Okay. And I was saying,
happy birthday.
No, not till September. Give me a little time. Not till September.
Oh, okay.
But I'm 60 and I'm coming down the steps to my little podcast studio here. And I was like, girl, I'm telling you what, I find the value of my core coming down the steps in my 60s. She's like, what? I said, balance. I'm like moving my core just coming down the steps. We are using our tongue just to function and eat and breathe and swallow. Wow.
Mm-hmm. It's powerful.
It is.
I mean, I could talk to you for hours. Actually, what I was thinking is we need to do some more stuff together. I just love everything that you're up to. It's really powerful. Tell me a little bit more, because I know I'm going to get inundated with questions. Okay. So you're not selling the rhinomanometer. You're not selling the product, correct, anymore? I
do.
You do? Okay. So, is it something I can purchase? Is it something that you teach? Is there a class? Where can we get more on this?
So, yes, I teach. Yes, I do the coaching. I actually have a certification program and a little mini residency that I'm going to be doing.
Okay.
It's on my website. So I'm going to do the science of airway function, diagnostics, and therapeutics. So everything's in my head. Everything that I've learned and built over the past 9 years, I'm going to put in a certification course. So I'm going to do, without giving too much information, but I really want to have that connection between medical and dental. So if you work with me, you're going to have to pick a few dental, if you're medical, a few dental components. And if you're dental, you're going to have to pick a few medical components.
When can we expect
Oh
that?
gosh, I'm hoping by fall. It might be pushed back.
Okay,
Because I'm actually
awesome.
creating a textbook. I thought if I'm going to do this, I'm going to do this right with textbooks and videos. And I've got some other people chiming in, with expertise.
Well, Karen, I would love to. I mean, we teach a lot of therapists. That's what what we really focus on. I would love to maybe team up and do a little, I'd love to do a little something because this is a huge missing part. And I do think myofunctional therapists I like to call them airway traffic controllers.
Yeah. I love that.
Meaning they really are. Yeah. Because, and they're important because they can really help navigate and make sure people touch down and get to where they need to go. And they can keep traffic moving very well. Or even, I love my analogies in a sense, or they're really great tour guides. You know what I mean? They know how to get you to the they can get you to the Eiffel Tower. They can get you back, bring you to lunch, and give you really important information along the way.
Well, let me ask you, what's the licensing behind? Because there's different levels of people that are in myofunctional therapy.
Yeah.
So
myofunctional therapy right now it's a bit of a gray area. So you have the speech group and you have the hygiene group. So I'm obviously from the hygiene.
The hygiene group I can't sell to. I can teach them the visuals. Okay. I can teach them the visuals on, what I see in a face, what I see in a posture, and based on visual exam, what high nasal resistance looks like.
So that's actually an interesting aspect that we could definitely, you and I could chat on. One of the things, I'm a hygienist, but I really work from a place of somatic nervous system. Where I look at this is that the breathing and the tongue have a lot to do with how the body is dysfunctional, how the body reacts. And just more like a personal trainer, where I actually think the hygiene community is a little strong, is they know the structure, the soft tissue, and they know the anatomy of the face in a very different way than the speech therapist does. Yeah. Now, the speech therapist is so good on the articulation and the movement and how things sound. But there's this missing piece, which you just brought up, and that is actually the thirds of the face. The face will tell you an entire story, right?
Absolutely.
Like where the central nervous system is, where the nostrils are overflaring. And the truth is, one of the areas that we work on is that when you're doing a full evaluation on somebody, you should be able to see how the face is actually confirming the tone of the voice or the airway flow and all of those aspects. And that's actually what I focus on a lot of. And then the teeth actually just confirm the story, right? I mean, if you look in somebody's mouth, right, it will just confirm everything. So I do think over the next 5 to 10 years, I think we're going to see a difference in the myofunctional therapy world. I do see it becoming its own profession on its own.
Well, Melissa, I'm going to interrupt you for 1 second. So for those that can't actually buy a class 2 device, I mean, when you think of it, the easiest way to know, can I do this or not? Am I able to purchase an FDA-cleared class 2 device and prescribe a test? That's the easiest way to think. If it's in your wheelhouse, if it's in your licensure.
So dentists can, as long as they're in a state that they're allowed to, correct?
Yes. It's the interpretation part. Yeah, it's the interpretation part of the data output, because now it's kind of okay, now you're interpreting data. Where is that blurred line? But here, I'm going to offer a solution. I'm creating something
like the sleep home study, like somebody else would read it.
Well, I can do the interpretations, but there's that gap, like you said, where people can't really buy the class 2 device. But I have a solution, I think, that will look at nasal resistance. That's all I can say.
Okay, that's good. You got something coming down the pipeline. That's what we need more of.
It'll be a way that y'all can do this, whether you're a dental hygienist or not.
Well, I think that is a great place where I want people to know that there are things coming down. I obviously have to have you back on because we need so much more. I'd love to continue the conversation offline and see even if I could even show you some of the work that we're up to see where maybe we could bring you in as I'd love to have you as a special guest or a special instructor on some stuff.
Absolutely.
Because the things that the things that we need to know as a community to be able to help these patients is crucial. So let me ask one quick thing. If I had a patient today, are you doing any telemedicine?
Yes.
Can we refer people to
Yes.
you?
Yeah, absolutely. So on my website, you can just email me directly. You're in Louisiana?
That's happened to be where I live, but Faceology actually covers the entire country, and most of our listeners from all over, they're all across the country.
Yes. So I am in 44 states and territories licensed, so I can do virtual. Some states I'm going to have to get like an individual license, like New York. They're killing me.
No, New York. New York likes to make everything difficult. New York and New Jersey tend to be a little tricky.
And California. So I can be like a coach, a coach. But for the most part, yes, across the country I can. So when you go to my website and you click on services, you'll see where I do mentoring, and you can do your form that way if you're a practitioner. And then on the other side is for patients. And even on my contact and inquiry page, some people want an interpretation. Some people want just a consult. Like, hey, what do I do? What does all this mean? Can you kind of give me a second set of eyes? I do that. I do in office, and then I do virtual, full visits.
Wow. So there's a lot of aspects to be able to
kind of accommodate. And then if you're industry and you want me to try your product and see, does it really work and help breathing nasal function? Then I do that as well. So I'm kind of, if you want to do a research paper, I'm like all across the board. I just want to have this like a la carte there's something for everybody.
Yeah, you can absolutely meet where everybody's at. So for right now, to wrap this up as we come to a close here, one last quick area we wanted to say is, I know we didn't where airway and AI, that's one aspect that you really are working a lot on. Am I correct?
Yes. Yes. So that was the Daphne score. There was a big deficiency on understanding the data for the acoustic rhinometer. Look at the mean cross-sectional area, the rhinomanometer, and the peak nasal inspiratory flow meter, or the PNIF. And so the PNIF, I actually wrote the mathematical calculation for the software. And then it took me like 10 months to write this whole logic and algorithm. It was a lot of work. It was 5.5 years of research.
I'm sure.
Yeah, looking at 754 papers and looking at all these different things. So I kind of have the roadmap of what's out there in the literature, but then proprietary is the things I've discovered that you don't see that's in the software, if that makes any sense. But I went back to GM and my boss and I said, hey, what's like normal? And he said, well, we don't know. We can't practice medicine. We don't have a license. I'm like, well, I do, and I can. So that's kind of what kicked this off. And that was back in 2017. And then Daphne was born in 2022. And so the way I have it set up is that all of the data that you input, it's web-based. So that way I can go in and change things and fix things versus have like a thumb drive. And I worked with the FDA as well. So the FDA, make sure it was kosher with them. So I wasn't like in this like e-commerce portion of the FDA. But so you can go in there and everything goes up into a cloud. I go into the cloud and I pull all the data down and I start looking at the machine learning aspect of it. What am I seeing? So for example, I can look at a woman of age of 40 does well with this and not this, because you have to enter devices, brands, medications. So I can start looking at all of this and see what's normal and not normal. And when it comes down to it, then that helps the practice to say, well, most of my patients are this and this age, and this product is really helping and this one isn't.
Wow. You're really doing so much work on being able to help people just understand and kind of really, I almost want to say you're like the top of the funnel and you're trying, I love how much you're trying to bring it all together. Really, really powerful. I definitely would love to ask a couple things. So if you had a group of myofunctional therapists just sitting in front of you right now, and you could give them 3 things that they should do today in their practice to help determine whether or not they need to see somebody like you or they need to feed, what would be your top 3 things, like just real quick?
Feeding patterns or eating patterns. Look at the nostrils.
Look at the nostrils.
And ask the percentage of time the child is sitting there with their mouth open.
Yep. Main things. And then from there, then you kind of determine what more we need to figure out. That's pretty
we need to
amazing.
look at the functional testing of what's happening in that gateway to our system.
So good. The one thing I just want to just finish up on, because I know I'm going to get asked. Do you recommend any gut testing? So like we were talking a little bit about that gut nasal connection.
Yeah.
Are there any gut testing or anything like that that the kiddos that we can send our kiddos or tell parents to check out?
You know, I don't know that much as far as the testing. I've seen there's some testing looking at genetics.
Yeah.
Some
genetic
company
testing
in Texas. I just saw it maybe a few weeks ago. I don't know much about it. That's where I go into my gastroenterologist and partner with them.
Yeah.
Because they know the most up to date as far as the science and testing and whatnot.
And the science and the gut.
Yeah.
I think it's a great correlation and super exciting.
Yeah.
Well, okay. So we know where everybody can find you. You have a great new website. We got some great new certification courses we're going to keep an eye on. I'm definitely going to be reaching out with you to bring you on. I'd love to have you do some bonus content on
my pleasure.
on our next aspect of stuff, because you are just a plethora of knowledge. One thing we end here on is I always ask everybody, what does mind your mouth mean to you? Or when you think of mind your mouth, what's the first thing that comes to your mind?
Mind your business, focus what you need to focus on, ask the questions and get an answer, and don't stop till you get an answer.
That is so good. I love it. Well, Dr. Karen,
I don't know if that's the right answer, but
no, it's perfect. There is never a right or wrong. It is always exactly what each guest feels. Well, Dr. Karen, thank you so much for hanging out with me this morning.
This is so fun.
And I am so excited for all the listeners to hear this. Please, guys, go check out her website. Go check out everything she's up to. Keep an eye on, because we are going to have her as part of the Mind Your Mouth community. So thank you, Dr. Karen.
Thank you so much. It's been a pleasure and an honor. And thank you, everyone, for listening. And I hope you find something, a little golden nugget of value and good information. Thank you.